If you or someone you know are struggling with depression, there's a lot of it about. An estimated 1 in 4 of us will be affected by this cruel illness at some point in our lives. But a smaller number of people are affected by a more tricksy version of depression, bipolar disorder, previously known as manic depression. Namely, an estimated 1 in 50 in the UK, and that's still 1.3 million people. You may be watching this because you're wondering about yourself or someone you care about. And in the case of bipolar disorder, the role of a partner, carer or friend can be vital, as we shall see. So this video will provide some information about bipolar disorder and how CBT may play a role in helping you or your loved one. Firstly, some definitions. There are 3 main types of bipolar disorder. Bipolar I has characteristics of manic episodes which involve euphoric highs, boundless energy, impulsivity, and possibly even psychosis. Depressive episodes may occur. Bipolar II, its characteristics are less manic episodes and possibly longer depressive episodes. Cyclothymic disorder is a milder but still difficult version of bipolar II. And the wave pattern of the illness can vary from person to person, but also for an individual over time. Some people have periods of calm in between the highs and lows. Others may be low for very long periods with rapid upswings, or anywhere in between. And the hardest part of your journey may be simply noticing and working out where you are at any one time. In some ways, the more extreme the manic highs are, the easier they are to spot in yourself or in other people. Periods of needing very little sleep without ever feeling tired, racing thoughts, vast optimism, acting on impulses. It sounds like a great day, hey? And we may all have days such as these, perhaps after getting a new job, achieving some landmark milestone, or falling in love. But if this is going on for days and days, and we've left our job, and we've maxed out our credit cards, or we've taken extreme risks with our own physical safety, maybe with drugs or vehicles or unsafe sporting activities, or put ourselves in dangerous sexual situations, believing ourselves to be invincible, this can be a major problem. And while booking a holiday to Barbados on one of those maxed out cards might be simply unwise, if your partner is talking about booking a trip to Saturn, then a further line has been crossed, possibly into a psychosis. So it's maybe the middle ground where the manic highs are not so obvious that confusion can occur and mania can be overlooked and unrecognized, particularly after long periods of depression. Often the sufferer does not recognize the manic pole, or even if they do, don't really see it as a problem, more as a blessed relief from the jaws of depression. I mean, who wouldn't want a great day, or 2, or 10, or 20? So we can see how bipolar disorder can often be mistaken for so-called ordinary depression or unipolar depression by the sufferer for 2 reasons. The depressive episodes can outweigh the manic episodes in frequency and duration. Plus, of course, because the depression bit just feels so difficult, that's what brings people to therapy or seeking help in the first place. And they may not even mention the manic highs. So if there is any possibility that you or your loved one is suffering from bipolar, it is really important to get a health professional involved in getting a diagnosis. And sometimes even a health professional can get so caught up in wanting to treat the depression that the manic highs are overlooked. The depression piece is hard enough, and at first glance, you might be prescribed antidepressants. However, you can imagine, although this medication can be quite effective in raising mood, it can tip a bipolar sufferer too far the other way and bring on a manic episode. So a proper diagnosis must be sought, as antidepressants on their own may be contraindicated. The first line of medication that your GP or psychiatrist will be looking at is a mood stabiliser, which can moderate both ends of the mood pole, and they may be combined with antidepressants or antipsychotics. So let's start thinking about the downs. Depression steals things that feel like they belong to us. Our sleep, our sense of enjoyment. People describe living behind a thick wall of glass. Our motivation goes, even our appetite. It can block access to good memories, but let the bad ones flood in. We look back, things seem dark. In the present day, things seem to demand a huge effort. It's no wonder people talk in terms of, what's the point in anything? Does this feel like this is happening to you or someone you care about? Well, hold tight. You're in the right place to learn how CBT can offer a lifeline. Let's start thinking about emotions. We have a little model of the person in CBT. You can see everything interacting one another. People come to therapy because they're dealing with unpleasant emotions, such as anxiety, powerlessness, anger, or depression. Emotions are big, powerful states, and people may tell you, you don't need to feel depressed or snap out of it. They may mean well, but they perhaps don't get how hard it is to do so. I mean, if you could have done that, you would have done it already, right? And probably not be watching this video. So that's the bad news. The good news is that we can make a difference to the other parts of ourselves. Namely, how are we thinking? What are we doing? And what's going on in our body? And if these three are working in our favour, then the emotions box has to kind of come into line. So I'm going to talk a little bit about the C, the cognitions, and the B, the behaviour in CBT, but also another B for the body. What's going on inside our physical bodies? And when dealing with depression, I prefer to think of BBC therapy, body, behaviour, cognitions, as I focus on the body and the behaviours first, and only then work with cognitions. So let's start thinking about the body with bipolar. The clinical guidelines for treating bipolar disorder follow the research on the best outcomes by recommending combining CBT and mood stabilising medication if the depression is severe enough. So a pills and skills approach. Bipolar disorder is less well understood than unipolar depression, and it's thought that it is largely a hereditary condition, although it may come about as a reaction to other adverse life events. It's widely believed that depression is linked to a low level of serotonin in the brain. Now, I'd love to be able to talk you out of having low levels of serotonin in the brain, but it would be a bit like me trying to talk you out of having hay fever. While I might be able to teach you skills to avoid hay fever inducing situations or to manage your symptoms, but if it's severe enough, you may well need an antihistamine. Likewise with medication. The pills can be a literal lifesaver, particularly if you're having ideas of hurting yourself or taking steps to end your life. CBT will teach you the skills to manage your depression, which the pills can't do. But the pills can provide enough symptom relief to help you learn the skills. If you are experiencing suicidal thoughts currently, you must let someone else know. Please go to your GP, or if they feel particularly compelling, go to A&E. You can call the Samaritans 24 hours a day on 116 123, or you can text SHOUT to the crisis text line 85258. And for anyone with depression, it's very important to stay close to your GP or your health provider throughout your recovery. So Google serotonin and you'll find a definition like happy hormone. So it sounds like an optional extra, like a glass of wine on a Friday night, right? But of course, it's a bit more complicated than that. Serotonin is involved in very basic bread and butter processes like sending us to sleep all night and waking us up refreshed. making us feel hungry and motivated to seek food, and then satisfied and able to stop eating when we're full, and allowing us to concentrate on our work. These processes are not optional extras. This is more about keeping the show on the road. So we can see if these basic processes are working, we feel an ongoing contentment. But when they start to go awry, we can very quickly start to feel pretty unhappy. So we can see depression as a bully that has, for its own reasons, decided that you are not going out into the world by robbing you of sleep, motivation, energy, making the things you used to enjoy feel flat, pointless. The key thing there is to see depression as that bully and deciding that we will not let it dictate to us what we do. Behavioural activation. The first line of fighting back that CBT encourages is called behavioural activation. We are designed to be active beings out in the world. We feel good if we are. So we're trying to reverse engineer good feelings by doing again the things that we would have been doing if we'd never had the depression in the first place, even though we don't feel like doing it, and even though it may not feel as great as it used to do. You know, if we can win 10 minutes back of good feeling regularly, that's a win against that bully. Specific behaviours call for other feel-good hormones, and so we need these to work harder for us if our serotonin is offline. Your CBT therapist will encourage you to be getting boosts from dopamine, oxytocin, and endorphins. Some of these you may have heard of. Let's start with the easy one, endorphins, nature's painkiller. GPs prescribe exercise for depression nowadays, and with good reason, because 20 minutes of brisk exercise can bring that runner's high feeling that can have long-lasting effects on mood throughout the day on which the exercise is taken. The other two come on and go off, so we need to do lots of little things throughout the day to give us little hits. Dopamine says, hey, get out on the planet and do stuff. And then once we have done so, it says, yay, look at you doing stuff on the planet. So you will work with your therapist to find 10 activities a day that give you a sense of achievement, however small. On a bad day, that might be brushing your hair or getting out of bed, and that might be a win. On a better day, getting on with some work. And it's important to talk to yourself in an encouraging way, such as, I'm fighting back, rather than in a demeaning way like, oh, anyone could brush their hair. Oxytocin is the cuddle hormone, driving us to get us close to other warm human beings, possibly to have sex, make a baby and look after it. So try and lean on others, your partner, your friends, your family. You're not being selfish, because as they boost your oxytocin, you will be boosting theirs. And you know, even if you're on your own, and we know that depression may want you to isolate yourself, you can boost this by seeking out nice things for your physical body. Its skin, its muscles, your eyes, your ears, your nose, your taste buds. This might be small things like having a bath, making a playlist that makes you dance or reminds you of when you used to dance, even looking for comedy clips on YouTube.
Harley Therapy, the UK's leading experts in therapy and mental health care, right here in London or online.
Because we're going to need 10 of these a day also. So your therapist is going to be urging you to do these things, recognizing it might not be easy, as the first step into changing your neurochemical mix and giving you a felt sense of small improvements. This is to encourage you to know that you are not your depression. It may be visiting you right now in order to bully you, but you can fight back. Lastly, cognitions, thoughts, or how we are talking to ourselves. I've already mentioned phrases such as treat depression as a bully, and I'm fighting back even though I don't feel like it. These are examples of making a conscious effort to speak to ourselves in an encouraging way. CBT invites us to step back and notice how our self-talk or inner dialogue can be negative and self-critical. With depression, we're under attack from our body with the low serotonin, from our behaviour being deactivated. And if we have a stream of thoughts like I'm useless, or others don't like me, or things can only get worse, that's a further attack. Critics of CBT say it's just telling me my thoughts are wrong, which would be particularly hard if depression is already telling you about so many other things that are wrong with you. But that's not what CBT is doing. It's aiming at trying to ascertain whether our inner voice is helping us, keeping us stuck, or dragging us down, and allowing us to amend it accordingly. Let me tell you a story. Imagine you're the goalkeeper for your favourite football or other team, and you've got a big match coming up. Your coach, an old school coach, comes out and says to you, "This match is vital. You've messed up so often before, so for goodness sake, don't mess up this time, okay?" Well, how would you feel? Ashamed? Humiliated? Terrified? And how would your performance be affected? Not in a good way, I guess. So let's send Coach A off the pitch. And let's send out Coach B. He's a young Australian surf dude type, and he strolls on and he says, "Hey, everything's going to be great. See you at half time." How might you feel now? At least not ashamed or terrified, but he gave you no guidance as to how everything will be okay, so he's also less than helpful. So, CBT is not Coach A. Your inner voice is probably giving you enough of him anyway. But it's not Coach B either. We're not just going to tell you to just think positively and everything will be fine. We know that life is pretty tough at this time and that thinking of unicorns is not going to work. So instead, your therapist will show you ways to be more like Coach C, who comes out and says, "I'm right behind you. We know that you already have some great skills. You always know whether the ball is coming from the left or the right. But to stop more shots, you might want to stretch your arms or even jump a bit to increase your chances. So let's give that a go and review at half time." So how will CBT do that? It's called cognitive restructuring. By noticing what we're saying to ourselves, we can check in whether this dialogue is kind, is true, is helpful. If it's not, it's what we call an automatic negative thought, an ant, A-N-T. And here are some ants with their little machine guns. These guys are guaranteed to have a downward impact on our mood. We can challenge these ants in two ways. Firstly, by looking at the content of the thought. Is this really true? Is there any evidence going the other way? What evidence might I be overlooking? And what might be a more balanced thought? We call these capability affirming thoughts, or CATs. And here they are. No machine guns. People prefer cats to ants. Secondly, we can challenge ants by looking at the process of our thoughts. Would I say exactly that to my best friend if they were in the same situation? Generally, we find people are much kinder, more encouraging to others than to themselves. What would I say to them? If that is kinder and more encouraging, maybe I could start saying that to myself. We also look for unhelpful thinking habits. Am I always predicting bad things will happen? And how does that make me feel right now ahead of time before anything happens? How accurate are my predictions? Let's check them out. Or we might need to make some better predictions or keep an open mind as to the future. We call this fortune telling. Am I also always working on an assumption that people don't like me, reading their minds without checking it out? We call this mind reading. And if we can allow the possibility that thoughts are not always facts, then we have something to work on. So let's think a little bit about using CBT for coping with the highs, the manic highs, as well as the lows. Paying attention to our cognitions is particularly important when it comes to working with the manic highs because they just feel so nice. So the first step is recognizing when they are occurring and working out if this is too high. This will be relevant at the point of diagnosis, but also later on during any course of medication. It can be easy for a sufferer to say, I'm doing so well, I don't need the meds. But by noticing our cognitions, working on that idea that thoughts are not necessarily facts, we can begin to develop a third-party version of ourselves, someone who stands outside of us, takes good care of us. I often use the metaphor that bipolar is a bit like a dog who will put us into its mouth and, like a rag doll, toss us from side to side. And we want to become the dog owner instead of the rag doll. With many disorders, including the depressive pole of bipolar, the unhelpful thinking habits are negative in tone. But with mania, they can be the opposite. Inflated self-esteem and wildly optimistic fortune tellers can blind us to the reality, and the speed of thoughts can be quite exhilarating. So whether our thoughts are overly optimistic or overly pessimistic, adopting a questioning stance, something as simple as a post-it note stuck on our PC saying, "Can we say that for sure?" may be enough to put a spoke in manic or depressive thinking, invite reality testing, and setting boundaries. When I work with bipolar, I always recommend this very jolly orange book, Mood Mapping by Dr. Liz Miller. She's a neurosurgeon and she also has bipolar, so she knows quite a bit about moods. And she has a nice, simple metric using two axes of energy and well-being to allow us to plot where we are. So this allows us to determine where we are and if we're where we want to be. So in mania, we're definitely in the action quadrant, but we shouldn't be so far out of the quadrant that we're making unwise, unhelpful or dangerous decisions. Are we lacking both well-being and energy? Are we tired, bored, exhausted, or are we getting towards depression? It may be time to take action to move one of those axes. When we're full of energy but the well-being is low, we're up, we're high, but we're anxious. And you know from our other videos that there's a lot that CBT can do to help with anxiety. But the last quadrant is also interesting. It's good well-being but low energy, so she calls it the calm quadrant. And maybe we need to encourage ourselves to inhabit the calm quadrant, such energy can bubble up for us. And the rest of the book has literally hundreds of suggestions on what we might do to move ourselves from wherever we are more closely to the quadrant that we are seeking. The other book I recommend is When Someone You Love is Bipolar by Cynthia Last. This is very helpful because, as you can tell from the talk, the role of the partner really is vital. There's lots of information on the web about bipolar. There's great talks by Stephen Fry, so feel free to find your own resources and references. Longer term strategies for bipolar. It can be really helpful to keep a long-term record of your thoughts and behaviours over time to track any pattern of changes, particularly if your wave pattern is particularly slow. Your therapist can help you with this at the start, and later your partner or friend can help. Together, this team can keep you within manageable bounds. You might need to work on a crisis plan with these guys to map out what triggers there might be for mania, some of the early warning signs, such as unenjoyable sleeplessness, with an agreed set of steps that you will allow others to take on your behalf if necessary. Overall, trying to keep a healthy routine of sleep and exercise can help with maintaining stability and allowing us to notice when we're slipping out of track. Simple, right? Yeah, CBT is very simple, and some say almost common sense. However, it's also very difficult because these thinking patterns, these behaviour patterns have become ingrained, and it will take conscious effort to check, to create new thought patterns, to practice new behaviours, and practice these often enough that they become the new default. But it can be done. We retain brain plasticity and ability to learn throughout our life. So, in summary, bipolar can be managed with meds and CBT. It's not necessarily easy, but the meds will help. With effort, we can manage the lows with behavioural activation and helpful self-talk, and enjoy the highs while keeping a kind and watchful eye that we're not going too high. So, practice makes better. Our job is to turn you into your own CBT therapist as quickly as possible. With bipolar disorder, that will mean assessing whether medication is needed. For the depressive pole, introducing behavioural activation. And for both poles, making sure your self-talk is always helpful and encouraging these changes until you can maintain them on your own.